for February 2026. Thank you all for coming. It's nice to see everybody. We've got a busy agenda today. We've got chronic pain as our kind of core theme today, and we're lucky that we've got the service lead from Leeds Community Pain Service. Looking forward to all those. She's only got 5 minutes, but I'm looking forward to hearing from her today. And then we've got some guys from Pain, Equality of Care and Support in the Community, who are a London-based organisation who've done some excellent work when it comes to chronic pain. And then we'll have a bit of a chit-chat afterwards about what we've gone through. So some housekeeping. Today's session's recorded, so we can share it widely with the ever-growing invite list for this group, which is great. If you don't want to be in the recording, then feel free to turn your camera off, and feel free to fire things in the chat if you want to, and our speakers will address them live if they can and want to, or we will just address them at the end. It's quite nice to hear chronic pain as our topic today, because in this morning's clinic, I think I've had 3 or 4 chronic pain conversations, and you know, it's something that we do every day in general practice. And a topic that, despite the best intentions, we sometimes find deeply frustrating, and can feel quite powerless and disarmed. So it's really nice to have some subject matter experts here to talk to us today. Have we seen Nikki, Lauren? Yeah?
Yes, I can see her there.
Great.
Yeah, I'm here.
Oh, thank you. I've got you. I don't know if anyone else has had this problem, but Teams in my desktop app is not working. So I've got to use Teams in my browser, so I can't always see everybody. Thank you very much, Nikki, for coming to join us today. I'm really looking forward to hearing what you've got to say and how things operate in the Leeds Pain Service. So I shall hand over to you.
Lovely. Hi, everybody. I'm Nikki Clay. I'm Clinical Head of Service. I work across MSK and the Leeds Community Pain Service. I have got a few slides. I'll just share those just so that we can just bring that through. There we go. So hopefully you can see that. Just let me know if you can.
Yeah, we got it.
You got it? Okay, lovely. So yeah, so I just thought I'd give a very brief overview. Obviously, I work for Leeds Community Pain Service, but we also work closely with the Musculoskeletal Service and the Leeds Tier 3 Interventional Pain Service. So I've done predominantly just a few slides about the community pain, but obviously incorporating the other teams as well within that. So who are we? Well, we're a holistic, multidisciplinary, patient-centred chronic pain service for non-cancer pain patients in Leeds who have pain for longer than 6 months, and that can be in one site or it can be multiple sites. It's a team of physios, nurses, mental health nurses, healthcare trainers, and specialists with specialist skills in helping manage the pain. And we are the only provider of these community services within Leeds. We've just listed a few things there about the NICE guidelines about management of chronic pain, which includes psychological therapy, physical activity, physio, pharmacology management. Acupuncture is in the NICE guidelines. We don't actually offer that within the pain service now, unfortunately. But we cover all of the rest of this, and we work predominantly, I'll go on to that, sorry, we work at some group-based and some individual one-to-one as well. So what we do, we take a holistic approach to improving the patient's individual function and quality of life, and one of the big things that I'm sure everybody out here or on the call is that it's very, very individual. And pain is all-encompassing and overwhelming for the patients, and often it is impacted by it isn't just the pain itself, it's impact of things like stress, poor sleep, social issues, to name just a few issues that can increase the levels of pain that each individual is experiencing. So it's not straightforward, and that makes it a very, very difficult area to manage. The patients are often very complex and got multiple comorbidities. They're often not working or having difficulty to maintain and stay at work. And obviously their symptoms are all long-standing. They've often failed a lot of other management. And community pain service is really sort of the last steps, really, when all other sort of physiotherapy and other treatments at trying to resolve the pain have been exhausted. So it is a pain management support, and it's tailored for each of the individual's person's needs, and the aim of it is to improve the quality of life for that patient. And that might be as simple as improving their sleep quality, or it might be enabling them to get back to work or play with their grandchildren. Or there's, every patient is individual, and we have to, we do a tailored program for each individual. One of the big issues that we have within pain is that the patients are often on high levels of medication, and we try to optimize that and ideally reduce the pain. Medications are too in use. We have some prescribers, non-medical prescribers who work within the service, but we don't formally prescribe or de-prescribe medications. We work alongside the GPs and pharmacists within the PCNs to reduce the pain medications. It's all advisory. We do have specific management with regarding pelvic pain, and that's a new and developing service. The Leeds Community Pain Service do not offer any sort of diagnostic or any further investigations. If the patients are arriving and this is their expectation, they are quite quickly referred directly through to either the musculoskeletal service, and predominantly it's spinal, so within the spinal treatment service, and we have a lot of cross referral. If also we have any concerns of the patients, for example, obviously anybody who has long-standing pain can still develop other things like cervical apathy, for example, or a new onset of acute radiculopathy, or severe osteoarthritis of their hip or their knee. They are also then cross-referred over to the spinal treatment service or to the MSK service to manage those more concerning and new symptoms. We work really closely with the Tier 3 interventional pain team at Leeds Teaching Hospitals, and as I said, we work with the spinal treatment service and also a new service within Leeds, which is called shortened to LEMAS, which is the Leeds Multi-Speciality Rehab Service. That's just been developed over the last few weeks. It went live, I think, early. I think it was the first week in February. It got pushed back from mid-January, and their remit it's an expansion of the long COVID service. They're dealing with a lot of the fatigue patients, not patients who have ME or CFS, but the patients who don't fulfill criteria for that specific service. So they're continuing to manage those the fatigue patients, but they have expanded their offer to include connective tissue problems or hypermobility syndromes as well. So there's an expansion of that service, and we are now starting to share generic groups across the two services, which is making it more efficient and enabling our staff to then be able to do more one-to-ones and sort of individual one-to-one services within the patients within the community pain team. We do signpost and work closely with the mental health services and social prescribing, and also we link closely with Forward Leads and accept referrals direct from Forward Leads, and it's a two-way referral pathway. We get referrals from mainly GPs. We get a lot of referrals from Leeds MSK service for those patients who have failed all physiotherapy options or non-surgical, yeah, so we get referrals from everywhere really. So a lot of patients come from the secondary care. They come back from Tier 3 or from spinal surgery or orthopedics. So we get referrals coming from everywhere really. We are specialists in managing persistent pain for the adult population of Leeds. And one of the big issues that we do have is about the engagement of the patients. Their patients really need to have exhausted all other therapeutic options before they come into the service. And initially that acceptance is quite a hard thing to do. And often patients they might not be ready for the service. They might not be at that point where they're accepting of their pain. And it's really only at that point that we can then start to work to improve the quality of life alongside the pain. And this is what we hope to achieve, is that their quality of life is improved. So that engagement of the patients is really, really important, and is that's the most important aspect, and encourages patients to improve and to change their lifestyle in order to manage the pain better. It is a community-based service. We work out of the health centres around Leeds, and we have a high concentration in sort of the low IMD areas of Leeds. So we work out of St George's, and Chapeltown Health Centre, but we also have sites around other areas. And we offer a face-to-face or a virtual service. And that applies to one-to-one initial assessment, and it also applies to groups. We do have some patients who are not even able to attend on a virtual group, and we have some pre-recorded groups that they can work with. And we have a high use of interpreting services throughout Leeds. So that's sort of a very brief overview. It's an absolute whistle stop of what LCPS. Has anybody got any questions before I carry on and just mention about the Tier 3 interventional pain service? I'm sure all of this is very well known to everybody.
Oh, I actually disagree. It can be really confusing which services sit where and who to refer when. So it's actually really helpful. Can I ask a question? What's your biggest gripe with your GP referrals? What do you want us to do differently?
I think it's about getting the patients ready for the service and the engagement. It is really difficult from a GP's perspective when we know that the pain patients, they have high numbers of attendances in GP practices, in A&E, their high use of NHS resources. Their ability to change and to improve their quality of life with pain is dependent on their engagement with the service. And I think actually getting that patient to agree that there is something that needs to be done, and that they are willing to engage with the service. I think that is the number one thing. We often get patients who, I think understandably, within primary care, this patient's appeared again and again and again, and it's like, I kind of just refer you through to the pain team. And it really needs to come from the patient. It needs to be offered to the patient. And is the patient wanting to get that understanding and to improve their quality of life? So I think that's the biggest gripe, is sort of referrals where the patients aren't engaged. We do have patients who kind of come around. We've had instances where patients have been referred maybe 4 or 5 times over a period of years. And on the first or the fourth time, they've not been ready to engage. They've dropped out, they've attended for initial appointment, they've dropped out of the groups, they're not involved, they're not really wanting to change the behaviour. But on the 5th time, it is the right time. And as I said, the patients are really complex. It isn't straightforward. They've always got loads of other stuff going on. Social issues is huge, mental health issues is huge, comorbidities is huge. They're a complex group of patients. And all of those things need to be aligned up. So if they've got we've had people who are sort of living in tents and things like that, who are homeless, and, their pain is almost, when we do a list of their problems, pain is probably number 12 and number 13 on the list of their issues, behind, I have got no money, I can't eat, I've got nowhere to sleep, I feel, unsafe, I'm going to, get beaten up. These are all of the issues that we have. And so unless all of the other sort of social aspects have kind of been addressed and at least being dealt with, then very often they're not in a place where they can engage with the service and improve their pain. So it is difficult. Sorry, that was a really long-winded answer, wasn't it? Apologies.
But the main take home from it, obviously we can't solve those social problems from a GP perspective, but the hard sell is what I'm hearing. Patients need to know what they're getting and get what they're signing up for. They need to know that this is they have to be an active participant in what we're offering.
Absolutely. And that is explained to them. They sent lots of information about the engagement and what the expectation is. If they're not able to actively participate, it just might not be the right time. It's the same way with smoking cessation. It's right that it has to be the right time for the patients. And I use the example of smoking cessation is a really good example, where it's a long-standing issue, but they've got to be in the right place at that point in time, capturing at them at that point. Any other questions? I can't see anybody. I can only see 2 people, so that's fine. So the pathway, this is what happens when they come in. So we have a referral that comes from primary care or from MSK or from wherever it is within the secondary care. They have an initial screening appointment with a healthcare trainer. At the moment, this is what happens currently, and that's where they're all already sent a load of information about how to manage their pain, given lots and lots of information resources to start that whole journey. And it's that drip effect with these patients very often. So giving us as much information from as many sources as possible has been really helpful. So they have initial sort of, we call it a screening appointment. It's basically an information about the service with a healthcare trainer. They're often then signposted to mental health services or to any other services, social prescribing at that point. Then they attend a Living a Better Life with Pain group, which is a face-to-face or virtual, or it can be online. Sort of pre-recorded, and that's where they are given a lot of the information about the science, information about the strategies, pacing, grading activities, a lot about the pharmacology aspect of things, and so really sort of a lot of information is there. And then they have their individualized pain management plan, which is one-to-one with a clinician, and then they have follow-up from there, and then they eventually leave the service. They can be under our care for a year, sometimes 2-3 years. They can be under our service for quite a long time, and that's okay as long as they're making changes and developing within the service. We then just tend to discharge with a plan back to GP. We are using patient-initiated follow-up, and we're finding it quite helpful because patients almost need that little bit of a handhold, and they're not quite ready to manage the symptoms or the pain on their own, or they can be referred through to the Tier 3 pain service. So that's the process. We are obviously, as I've mentioned before, working alongside the LEMAS group to access some of their relaxation group, and there'll probably be increased joint working moving forwards into the future. It's a really small team, and we get a lot of referrals. So we have about 300 referrals a month, and we've got, I think, 5.3 full-time equivalent clinical staff and 2 healthcare trainers. So it's a tiny, tiny service. So we do the best we possibly can with these patients. We are going to be developing the service moving forwards, but this is how it is currently. Anybody got any questions? And I'll just talk about Tier 3 just a little bit. No. So Tier 3 interventional pain management. So these are for patients who require intervention, essentially, is the way I would look at this. So this is people who require spinal cord stimulators, medium branch blocks, radiofrequency lesioning, some cord epidurals, occasionally transforaminals. So it is that sort of neuromodulation type service or injection type service. The Tier 3 interventional pain management team is led by 5 consultant anaesthetists, and they have a whole host of people who work alongside them. A lot of research is done within that team, and they have a lot of clinical nursing staff who work along with them as well. They also have psychologists who work within the team, and they're directly dealing a lot with the neuromodulation side, but they have reopened some psychology for a very, very small number of select patients. And that's the only true psychology service there is available for pain in Leeds. So the numbers that go through to psychology is tiny. The rest of them generally are managed within the community service, and you probably noticed that we don't have any psychologists who work within the community service, but we have CFT trained clinicians, and we have nursing staff who are mental health nurses as well.
Nikki, I'm really sorry to interrupt your agenda.
Yeah, I'm pretty much wrapped up there.
5 minutes. Was 5 minutes.
And we're done. Yeah, so that's it. Literally, that's the last slide. So that's perfect timing.
Great, that's really good. Thank you very much, Nikki. It's really interesting, and it's from a primary care perspective, it feels confusing, and actually that feels a little bit validating, because I think there is quite a lot to it. Like, there are a few services there, and they've all got quite specific requirements. From a GP perspective, when we refer, do we refer to the same place? Like, is it always MSK pain, and then you triage them to where they need to go, or are they separate referrals for Tier 3 versus community?
So community pain, you can't refer directly through, primary care can't refer directly through to Tier 3. It has to come through Leeds Community Pain Service. So if they're specifically wanting injections, they would always have had all of the other interventions first. They can't really just be going straight through for injections on its own. And the same applies for all the neuromodulation type work. So that has to come through Leeds Community Pain Service directly to get through to Tier 3. If the patient has exhausted physiotherapy options, then and they've already been down the MSK route, or they just don't want to go down that route, or the non-surgical, there isn't a sort of therapeutic any measures specific, no surgical options or anything like that, they can be referred directly through to the community pain service if they've got long-standing pain over 6 months. Anything that there is a sort of physical aspect that could be improved upon, then I would refer through to MSK first, and we can always then forward them through to LCPS if need be.
That's great. Thank you very much. Thanks for a really interesting topic. I think if anyone else has any questions, then if you put them in the chat, and hopefully Nikki can field them in the chat or email or something. So with that, we'll move on to our next speakers, and these guys come from PEACE, which is Pain, Equality of Care and Support in the Community. And we're really grateful for you guys coming up to share your expertise. I've already made my excuses, but I've not met these three before, so I'm going to let them introduce themselves. So I'll hand over to them.
Thanks very much. My name is Jessie McCulloch. I'm Programme Director of Mind and Body, which is part of King's Health Partners, an academic health science centre in South East London. And the Mind and Body programme is set up about integrating mental and physical healthcare. And one of our projects has been PEACS around chronic pain. So I'll just start sharing my slides. Hopefully you can all see that okay. So I'm joined today by my colleague Safraz Jaraz, who's one of the consultant psychologists, and Angela, who is one of our experts by experience. And we're telling you a little bit about this pilot that we ran, which was how we wanted to develop a much more equitable, community-rooted process for people living with chronic pain, recognising that this work sits right at that intersection of health inequalities, recognising the need for system transformation in terms of how we offer care. And so our learning from this work in South East London in Lambeth is really about how we design with communities and not for them. So there isn't a community pain service in Lambeth. We have a Tier 3 service. But this was about how do we work with the strength of our partnership and our systems. So colleagues from Talking Therapies, our place-based colleagues in Lambeth, our primary care network, as well as clinical community partners, and also people with lived experience. So PEACS was set up with some funding from one of our local charities, Impact on Urban Health, and it came from some of their work which was looking really into multimorbidity, where they recognised that chronic pain was both a gateway potentially for multimorbidity, but also an area which was particularly underserved in our local population, particularly people from Black backgrounds. And this work, I guess, really sits in that national direction of travel, where the NHS is trying to get to thinking about moving away from reactive episodic care and being more proactive and community-based in the support that's offered. This was something that we really found was needed in our area. Not only because there was a high demand and need for chronic pain support, but also that we were seeing real inequity in who was accessing and benefiting from the support that was available. Some of those more traditional models meant that we weren't getting the same outcomes that we expected. And so we tried a new approach, which was bringing in concepts around lifestyle medicine along with behaviour change, making sure that that kind of psychological safety was embedded throughout, really empowering people with lived experience to self-manage effectively. So from a perspective in our area, we knew about 1 in 3 people were living with chronic pain. It's the second most common long-term condition, and that this was really disproportionately impacting people from deprived areas. And I think, Nikki, you've already described a very similar picture in Leeds as well. Many people were perceived as frequent attenders. They may be experiencing obesity or other long-term conditions, be it musculoskeletal, but also we were finding with diabetes, heart disease, and areas that were really impacting mobility, for example. And we know chronic pain is a factor that is really demonstrating that inequality gap. We know it's going to become one of the most prevalent conditions by 2040, and that long-term condition prevalence is much higher in Black backgrounds, and particularly Black women. So before we talk a little bit more about what the actual intervention was, I'm going to hand over to Angela next, who's our expert by experience, who'll share a little bit more about our process for co-design and your experience of this intervention. So over to you, Angela.
Good afternoon, everyone. Thank you for inviting me to this session today. So I live with chronic pain. I have multiple chronic pain conditions such as gout, fibromyalgia, cervical disc disease, and lumbar disc disease, also with a pinched nerve affecting the whole of the left side of my body. So I took on this role to represent a wide range of people because the types of pain that I have are completely different, ranging from stabbing pain to dull pain to sharp pain to toothache pain to a pain riot, which I call that when everything's kicking off at the same time. So with this particular project, the PEATS project was basically a lifesaver for me, because at the time when I was offered to go on it, I was in temporary accommodation, living with all of the pains. At that time, I was actually having pain riots on a daily basis. So the PEATS project actually works in very closely with the patient, speaking to us and listening to us, because what we found is that the doctors have a very short time for appointments, so we're kind of rushed through. And with, like, because my medical conditions are complex, a 10-minute appointment is not going to be enough for me to go through exactly what I'm going through. And we found that with the PEATS project, there's a lot of empathy, a lot of understanding. They took on exactly what we felt and how it will be beneficial for us to actually do a new project, because also there's a lot of distrust with the NHS because people's own personal lived experience. So this is something that is very, very important when you're dealing with chronic pain, because unless you actually live with it, you don't actually know what a person is experiencing on a daily basis. It's just every day that we're living with this pain, different types of pain. So we found that this being community led, it was brilliant because it was local to us. We didn't have to travel too far to a clinical setting, and that built up trust between us and those who had put this course on. And it's just something that has changed so many of our lives. In fact, we call it the pain family now. That's how connected we've got with the community, with each other. And I really do hope that Leeds does take on something like this, because there's so much people out there in desperate need of help.
Thank you so much, Angela. And this was very much taking this a proactive approach in terms of how we identified people who might need that support. And I'll hand over now to Safraz, our clinical psychologist, to tell us a bit more about the work that we did and how we went about it.
Yeah. Hi, everyone. Thank you very much for inviting us. My name is Safraz Gerard. Like Jessie said, clinical psychologist, and I was the clinical lead while we were running the PEAKS pilot program. So much overlap with what Nikki was saying, so really good to hear that there's some common principles that we're putting into place. Now, the one issue that was raised was around engagement. And I think this was where this particular aspect of PEAKS, I think, can really add value to the way we try to engage people. Now, there are structural inequalities built into most healthcare systems, and there's lots of good evidence to support that. What there isn't as much information on is how do we address those? in terms of getting people through the door, in terms of engagement, that's where one of the structural inequalities lie. And a potential challenge of the GPs, the frontline kind of healthcare professionals making the referrals into a pain kind of pathway is that there's some filtering going on there. Not everyone who is in need of a pain service is being referred, is even showing up. Some of them are, some of them aren't. So one of the, I guess, different approaches that Peaks was able to take was the establishment of a chronic pain register using the EMIST system and an algorithm that identified people who are going to either have a diagnosis or, because of their other multimorbidities, are highly likely to have a diagnosis of chronic pain. And for us to then use that to proactively contact patients in the community, so that we can try to reduce and mitigate for some of the structural biases in terms of who actually is referred and ends up receiving a service. Josie, would you mind going on to the next slide? So just to give you a bit more of an overview of some of the key aspects of the Peaks approach, which I'm sure you'll see have some overlap with what Nikki was saying, is that it started off with this co-design process that Angela sort of alluded to, where actually we went to patients to say, if we were setting up a pathway, what is it you would want in it? To help us kind of challenge some of our own institutional thinking and ways of doing things. And they highlighted key principles around being listened to, being heard. They highlighted principles on the importance of kind of the social aspects, the psychological aspects of chronic pain, but also how chronic pain isn't just something that feels like it can be addressed with a couple of sessions, and people's experiences often were that they were sort of just chewed up by the system and then spat out. And just leaving them feeling still quite disenfranchised, even if many of them may have had for a period of time, a helpful and satisfactory experience of healthcare. So trying to incorporate some of those principles into the design of this pathway, we recognized, and this is of course supported by the literature, and as you can see, the NICE guidelines, not taking a biomedical approach, taking a biopsychosocial approach. So that was really, I think, a critical part of the approach here. And then, again, going back to what Nikki was saying about engagement and the importance of engagement, and having a more inclusive kind of design, something that was going to be much more relevant, individualized, person-centered, and really incorporated a self-management option, which is often hard for people to come to terms with when they're in distress and they just want an answer from you as a healthcare professional. So I'll talk a little bit more about how we tried to develop that. And I guess in order for this to be sustainable and work to the strengths of the different parts of the healthcare system, primary care, secondary care, but also the voluntary and community sectors, to really better meet the needs of people with chronic pain. Jesse, if we could go on to the next slide. So this maybe mimics slightly Nikki's sort of pathway diagram. So we do that patient search rather than necessarily having just direct referrals from GPs, although that is something that we're planning to incorporate into the sort of scaling of Peaks. But then once we've kind of got that register and we're targeting proactively which segments of this patient population are experiencing the most inequalities, which might be based on their gender, their ethnicity, their socioeconomic status, so that we've got a representative sample of people accessing the services, rather than just those that are more acquainted with healthcare, that have better relationships with their GPs and officialdom, I guess. So once people are in, we go straight into this engagement bit, which is the introductory workshop, which really talks about and understanding of pain, the science of pain, like Nikki mentioned, you know, in one of the earlier workshops in the current pathway there in Leeds. And I think it's really important for me to highlight from that frontline perspective, you know, what's going to help with engagement, and it's really differentiating chronic pain from acute pain. And I think if there's anything that sort of frontline healthcare professionals who might be doing the referring can really help with, is start to loosen up this idea that chronic pain is different to acute pain, and therefore needs a different approach. You know, an acute pain approach might be much more amenable to a biomedical model, but a chronic pain approach now needs something beyond just medication. And so we refine that further in a sort of a holistic one-to-one assessment where patients feel, you know, that they've had the opportunity to be heard, to be understood, and to be part of selecting, you know, what their treatment is going to look like. We then have an MDT review for those clients that we've assessed that we think need further discussion, and then the lifestyle medicine workshops, which I'll kind of speak to in a moment, before sort of following up. Having follow-up reviews to see how people found that process, and including how we now link them into ongoing community support, by including, and I think this is really important part of the Peaks project, was a peer support group, an ongoing peer support group, which Angela referred to, you know, then blossoms into the pain family. Next slide. So I hope some of you will be familiar with the lifestyle medicine principles, but this really helped to structure and align with the co-design feedback that we got from the initial consultation with people living with pain, and starts off with this biological, then moving on to the sort of the psychological, and then the social aspects in an integrated cross-referential way. So we started off with movement, you know, a movement workshop in a group, facilitated by a physiotherapist, went on to talk about healthy eating with a dietitian, also had a GP talking about medication, the pros and cons of medication, but also other, you know, potentially harmful substances, before talking about sleep. So this kind of represented the more biological aspect of the biopsychosocial element. Then moving on to myself and other colleagues facilitating emotional well-being, mental health workshops. One workshop focusing on mental health, and another one focusing more specifically on trauma. You know, it particularly reflecting what the evidence is telling us about the high prevalence of trauma and PTSD in clients with chronic pain. So equipping them with some principles, some practical takeaways, but also opening up the possibility of referral to things like talking therapy services, where actually some of that parallel work can really help them in sort of helping them to manage the impact it's having on their nervous system, and part of what predisposes them to chronic pain. And then wrapping up with a couple of workshops on relationships and community. I think that's about where I was going to get to. I think I'm back to Angela.
Thank you. So let's move on to community. Community is so important, so important. When I think about when the Peaks project began, as I said, I was in temporary accommodation at the time, off sick from work. In the daytime, I'm a civil servant for the last 25 years, but during that particular period, I was housebound and just rolling in pain all day long, until I had this phone call from a member of staff on the Peaks project who actually spent time with me on the phone and listened to what I said. And that pulled me out of the bed, because going to the hospital, that in itself caused anxiety because it's a clinical setting. And for me personally, I'm a cancer survivor. So every time I go to the hospital, that flashback would trigger off something else, which would aggravate the pain. So being in the community somewhere which is near and that you're familiar with, or even if you're not familiar with it, it's local. There's not a lot of travel having to get there. Makes so much of a difference seeing people who live in your community who actually lives with chronic pain, because it's invisible. You've no idea whether somebody has chronic pain or not. So being in the community is such a brilliant thing to when it comes to chronic pain, that we're able to go somewhere which is local, and we get to meet others who you don't know has chronic pain. So there's a connection in that aspect there. And that's where the peer support came into, why I call it the pain family, because now we're able to speak to others about the pain, what we're doing for the pain, what may assist with the pain. And just having somebody who knows what it actually is like to live with the pain makes so much of a difference, because as the saying says, who feels it knows it. You know, when I was at work, my managers used to always say to me all the time, but you look well. So unless I'm crying or leaning over, they wouldn't pay any attention to me. But I'm in pain every day. It's just a different level. You know, the ranges is different between 5 out of 10 to 10 out of 10. And obviously 10 out of 10, you'll have to physically see it. So being in the community is a brilliant thing, because going to hospitals, there's too much memories of perhaps bad experiences at the hospital, where in the community people feel safer and it's somewhere local, and peer support is it's incredible. In fact, you learn to have friendships with others. You get to go to a peer support group. We meet on a Friday for our peer support group, and it's so refreshing. Even when you're in pain, will struggle to go to there just to be amongst others and have conversations, or laughter, or do an activity to assist us, just to take our mind off the pain for a short length of time. It makes so much of a difference, and it's a crucial thing that needs to be put into place within everyone's community. So yeah.
I might just add one more point to that, which was we did have a parallel online pathway, which sounds like something that's you're doing in Leeds as well, just because not everyone can access community located services, mobility issues for some people with chronic pain, but also kind of carer responsibilities and even work commitments.
Thanks, Angela. Thanks, Safraz. Safraz, did you want to take us through the evaluation?
So we did have an independent evaluation team doing a quantitative, qualitative, and using sort of implementation science. Some of the key outcome measures we were looking at included the WHO called breath, so quality of life measure, similar to sort of what Nikki was saying, because with chronic pain, it is by definition this is going to be a lifelong condition. This isn't necessarily about us reducing the pain, but better managing the pain and living a better quality of life with pain. So that felt like a useful measure to use, alongside sort of pain catastrophizing, which we could kind of target more specifically, particularly in some of the wellbeing workshops, but also kind of the impact on the wider system. What is the healthcare utilization? Are the right people getting the service? I guess just in addition to these outcome evaluations, there's also an ongoing process of evaluations. Every quarter, after each sort of cycle of workshops, we'd take feedback from service users and to further refine and improve what we were doing. And I guess one other relevant measure was the qualities. What's the economic evaluation, because this is another key part of our NHS context. In terms of the results, if we can go on to the next slide, Jessie. Thank you. With an even smaller team, that Nikki shared with us, which I guess is still a thin stretch across Leeds. In this small chunk, we had a bit of collaboration, so a couple of sessions over the course of a year, along with myself working sort of part-time and an assistant. We managed to reach just over 1,500 people. And in terms of representation, we really were able to hit the mark of including 70% of people from the Black community, and further representing the sort of the prevalence data, Black women of a particular sort of age group. So I think this is evidence of how taking a proactive, targeted approach can help us to better address some of the sort of the inequalities. In terms of what people are saying, 89% recommend peaks, 79% feel more confident in managing their pain. And no one's saying that I'm experiencing less pain per se, but that was never going to be the target that we were aiming for. Statistically significant improvements in people's sort of psychological, environmental, and physical health domains on the WHO core breath. Reduced sort of prevalence of isolation, stronger social connections, and improved self-management and confidence when it comes to chronic pain. So from service users, from some of the data we got directly from them, some really encouraging results. Looking at sort of healthcare utilization data, we've got a 58% reduction in GP appointments. Like Nikki pointed out at the end, and many of you here tuned in will recognize that a huge proportion of patients who are those high frequency attenders are presenting with chronic pain. So actually, in terms of the impact this can have on service utilization, this is really significant. Also, many of you will be familiar with the agenda, the deprescribing agenda, and so we've got really helpful outcomes here in terms of the reduction in medication prescriptions. And I guess I'll hand back to Jessie just to kind of talk about the recognition this work has received.
Thanks, Saf.
Sorry, am I allowed to add one? Sorry, am I allowed to just add one addition, please?
Of course.
So, in addition to attending the Peace Project, what it helped a lot of us to actually accept the pain, because when you're living with pain, you're convinced it's going to go away. That it's it's when you're having a good time on the medication, you think it's going to go away, but it doesn't. And they assisted us, to prepare us to live, to live a better life with it. But it's just the acceptance. And I found for myself, when I accepted that this pain was with me, I called it the unwanted visitor, is what I called it. That once I accepted that, I realized that I can't just stay in bed in pain all day. I'm going to have to start doing something, because I've always worked since I've been 15, so I haven't known any different. And obviously I did love my job, and that's what assisted me and helped me to be able to get back into work with reasonable adjustments put in place for like flexible working, etc. And it's a lot of people, if they haven't reached that stage of accepting that the pain's going to be there, it makes it even more difficult. But once you get to that stage, and that's why I help the ladies who come to the peer group, because some of them are still at that stage. This is why the peer support's so important. Some of them are at the stage that I was at. No. So when I speak to them, and it's coming from somebody who's experienced it and still experiencing pain, it's very, very beneficial. Okay, thank you.
Thank you, Angela. I think that is so important. And, having somebody that really understands where you're coming from makes a big difference, and helps with that trust in communities as well. So we were successful in getting highly commended at the HSJ Awards for Innovation in Reducing Healthcare Inequalities. And we're now in a position where some of our neighbourhoods are wanting to adopt this as their neighbourhood model in terms of their integrated neighbourhood teams of providing that proactive outreach and much more sort of biopsychosocial education and support in terms of providing that wraparound care. And we've been awarded funds from Arthritis UK to develop a kind of train the trainer model and toolkit to facilitate other areas in adopting this in terms of some of their underserved groups. At the moment, our focus is very much on chronic pain. There are discussions about whether this model might also be suitable for other long-term conditions as well, given the overlap and complexity. So we're delighted that it has been so successful, and you know, as Nikki said, there are lots of parallels in terms of the service that's offered. I guess it's about how do we make sure that when we're thinking about pain, you know, we are able to go into communities in the way that's offered in Leeds, which isn't reflected in some other areas and other communities. So this is sort of our thinking about how we might be able to develop this and adopt this within neighbourhood models of care as we go forward, thinking about some of those shared barriers around long-term conditions, opportunities of working at a system level, and really embedding peer support, social prescribing, community-based work within our pathways of care as well. So thank you very much for inviting us today, and we're very happy. I know we haven't got very long, but if you have any questions, we'd be very happy to take any questions further.
That was a really fascinating talk. Thank you. Thanks for all three of you for your really expert insight. I mean, those results are, you know, remarkable. That is, you know, the reduction in GP appointments, obviously from a selfish perspective, is crazy. Like, that's so remarkable. So well done. Have you got advice for people who, from a project perspective, like, how do you even start on a project like this? Where did the funding from the project come from, and how did you get it off the ground? Because it seems like it's obviously a great idea, but how do you even start with something like this?
Well, we were really lucky in that we had a partnership with a charitable organisation who was wanting to address health inequalities for communities, and so we already had that relationship with a PCN who were already coming up saying these are the issues that we're facing as GPs. This is what our community is experiencing. You know, how could we do this together? So that it was very much, that was our starting point. And then we had a co-design partner who was able to go and speak with communities, who was able to kind of understand the issues from both clinician and our population's perspective, to come up with suggestions about what we might do differently. And then that was when Safraz was able to join, and later Angela, and very much we wanted people with lived experience to be part of that journey and part of that design process. And certainly as we go forward into this opportunity to think about how we might be able to share some of this nationally, we'd be really keen to continue those conversations with people in different parts of the country, people with lived experience, to understand those needs, because our context in Lambeth is quite specific, but I think some of those principles are likely to be really common across the country. But Safraz, you may well have
just add to that point, Matthew, that data is really important. And so when we became more aware of the dire need and the dire inequalities, that then prompted some discussions, and that's what got Impact and Urban Health a little bit more interested in investing in you know, a different pathway. I think that there is another sort of broad message I'd like to try and impart, and you know, just reflecting on Nikki's presentation of what you've got in needs. It's not like there's, you know, that's great what you've already got going, and maybe there's just sort of refinement to that. Hopefully, you know, there are things we can learn from the Leeds experience, but hopefully there are things from our experience that Leeds can benefit from too. But I guess sort of fundamentally thinking about how we change our view of long-term health conditions from being exclusively biomedical to something a bit more biopsychosocial, and how we might adopt a slightly more humble approach to thinking, okay, as health professionals, we've got the research and the evidence base, so we know it all, and say, actually, you know what, maybe the people who are living with this should have a allowed a voice in how we develop services.
I think that's one of the things that shines through from your work is you actually didn't just say we're doing co-production, you actually did it. Co-production is one of those things that people talk about a lot and don't actually do, but it sounds like you guys really did. So thank you for coming to present to us. Really appreciate it. We are now really short on time, but not your fault. This is us for jam-packing the agenda, and thank you very much. So now we're going to hear from Jane and Eloise from Eclipse, if you guys are on the call.
Yes.
Thanks. Do you want to
say
kick
before
off,
we do,
Jane?
any questions for the last guys, please put them in the chat and we'll field them by emails and chat if we can. But sorry, Eloise and Jane, over to you.
Go on, Jane.
Hi, very quick opportunity. We wanted the opportunity to flag a project that was launched back in November. It's called the Elevated Childhood-Led Interagency Prevalence Study. And we are partnering across a number of universities, myself at Northumbria, with the UK Health Security Agency and the Health and Safety Exec, as well as Leeds NHS. And we are recruiting and sending out lead sampling kits to parents to use to collect a few drops of blood with their children, and then that blood is coming back into our lab. So it's a feasibility study. We have just recruited the first 100 participants. We will have another 400 test kits going out in the middle of March, and then we're going to a poster-based advertising system for people to self-enroll, and we're putting those posters up in the community paediatric hubs, and they're also going out to the outreach clinics in the specialist inclusion learning centre schools. That's it in a nutshell. As the parents get the child's blood lead result, we are working with the local health protection team, particularly around elevated blood lead levels. But at that middle level of elevation, the parent or family may come forward to the GP with this letter. So we're really just trying to raise awareness of this study that's going on across Leeds. Thank you.
Jane, I think I know about that study because I think I got an invitation in the post. Did you do a big postal campaign?
We did. We sent out 150,000 letters to addresses that were literally just from Royal Mail. So we didn't know who had children, and therefore from that mailer campaign, a family could self-select to take part.
You know, I almost did. I got onto the website, but then the questionnaire was too long, and then I just didn't do it. So I'm sorry, because it does look like a worthwhile study.
Thank you. We just wanted to make sure people had awareness of it. And if there are any questions, yeah, there is a website. Please get in touch with us. Fantastic. Thank you.
Great. Thank you. Now that was a concise summary of a project. Well done, Jane. That was remarkable. Okay, everybody. Well, unfortunately, we really haven't got much time for chat and discussion today, so I'll kind of draw us to a close there. The next meeting, as you can see on your screen, is on the 22nd of April. And interestingly, again, it's about case finding, which is kind of becoming more and more of a message. You know, when we talk about how we tackle inequality, sometimes part of, well, a big chunk of that is actually going to the people who we're talking about trying to help, and that's whether that be proactive case finding for chronic pain or whether that be proactive case finding for hypertension. Who's doing that presentation, Lauren? Do we know?
It's Dr. Phil Zhu.
Okay, and where are they from?
Oh,
no, I'm
you're
sorry, I'm
testing
putting you on the spot.
me, sorry.
I'm sure it'll be a fabulous speaker because they always are. So thanks everybody for turning up today, and thanks very much to our speakers for sharing their great projects and experiences, and thanks to Nikki for coming to talk to us about the Leeds Pain Service. And we'll see you all in April.
Thanks, everyone.
Thank you.